Yay! There we go. I can start to see some people popping up. So Gilda Bungalow. There we go. From Houston. Just a sec. Thank you very much. I'll put this down here just out of the way. There we are. So you can still see me. Perfect. Right, so thank you very much for joining us on our live video. I'm going to keep my glasses on. I know it's a bit distracting with the screen there, but it just makes it a little bit easier for me to see what's going on the screen in front of me. So thank you very much for joining us today. We've got, this is the biggest wax and skin removal we've ever done. We had such a lovely gentleman came through the clinic, I think this week, I think it was, came through the clinic last week, sorry, and he was an absolute trooper, came through. We took a lot of debris out of his ears. So we thought we'd do this format. We do it live. So what we're going to do tonight is we're going to basically do the video first of all. Once that's done, we're going to do a bit of Q&A afterwards. What I wanted to do before the video started was just to explain to you guys what you're going to be seeing in the video. I won't take too long because I know you're all eager to get into the video itself. Mrs. B isn't going to be on camera with me tonight, but she is here helping me out. So that's who's popping all these little bits and pieces on the screen there as well. She's helping me out with the software in the background so I can concentrate on what I'm doing. So the gentleman that came through to clinic, which you're going to see in the video today, had undergone some surgery called a mastoidectomy. Now, I've got the big ear here so I can explain this to you. So basically, the outer part of the ear canal here, we know, the inner part of the ear canal is surrounded by your skull here. So this little bone here is called your mastoid bone. It's got all these little red circles you can see there, a little tiny air pockets, and it goes all the way around, you can see, to this side as well. Now, what can happen in some cases is you can actually get infection which sits inside these little air pockets here, which is really, really difficult to treat and really painful. So what happens in some patients is they actually have to have part of this bone removed. It usually tends to be around the back here. And what that effectively does then is it widens out your ear canal. So whereas the ear canal should be more sort of this shape, what you get then is you get quite a large cavity appearing there, which does need to be cleaned out quite regularly. Now, obviously, it's difficult for some patients to get back and forth to see their doctors to get that done. And this gentleman's come through. He hadn't had it cleaned out for a little while. So that's what we're going to show you in the video tonight. So that's the background to it. So without further ado, I'm just going to borrow my mouse back off Mrs. B. There we go. And we'll just get rid of this bit right here. So if I pop the video on, it should pop up. There we go. Okay, so what you can see here, we were talking about that mastoid being removed. I've just stopped it here. So what basically the surgery goes all the way around those little arrows there. So it goes all the way around there. Now you'll see the eardrum is what I'm pointing to there. So we've got a flap of skin which is sitting in front of the eardrum. And what at first glance looks like not very much debris around the left-hand side. So what we're going to do first of all is just use the standard size Zollner tube. Now this debris will be a mixture of skin, wax, basically lots of things all mixed in together. But at the moment we don't really know how far back this cavity goes. So we're just being quite cautious to start with, just gently lifting all these bits and pieces just off the side of the canal wall there. So we've got the standard size Zollner tube in here. You can see the nature of this debris. This wax is quite thick, quite sticky and pliable, almost like a toffee consistency. So we're just lifting this off the canal walls. There you go. You can just see it's just starting to peel away and break away a little bit there. Now, look at the difference in the consistency when we come to the top here. So we've got this sort of sticky material to the left-hand side, but the top portion of that material is really hardened up and quite dried out, which makes it really, really tough. So we're going to use the Jobson horn now just to get into that more tougher type wax at the top and just pull that down. Now at the moment I don't know how deep the cavity goes, so I'm trying to be quite cautious and stay just on the outer edge of that wax and debris. But you can see we've pulled down quite a large chunk there. Did you see how it flexed and just bent backwards, and it's really sticky and still holding on to that material behind there? There we are. There we go. Okay, so just coming away nicely. Just see how tough that is. It's really holding on to the material behind. So really just hanging on to that section. There we are. So that's come away there. We can actually see, look how it's pulled more material and more debris out there as well. There you go. You can just see that we're just pulling this down now, just slowly working it out from that right corner. Now we've got this really tough material here that we're trying to get through. Now, when you get this kind of tougher material, you do have to put a little bit of pressure on the Jobson horn there just to pull this down. I can't stress enough that this gentleman was an absolute trooper during this whole procedure. I know he's actually watching this tonight as well, so I know he's on here looking at this. But he did so well, because it's not so much that it's uncomfortable, it's a really odd sensation, because if you imagine you're pulling this out of a cavity, look how tough that is. You can start to see the skin pieces in here as well now. See how they're bending? There you go. See how that pulls down there? There we are. You can see the skin debris there now. See that sort of rippled effect? There you go. You can see it more clearly there. That sort of ripple effect you have there, you can see that's all skin. And it is really quite toughened up. Now, if you imagine when the skin detaches, it becomes really dry, so it really toughens up. So imagine it not like a leather, but a really hard piece of skin. So I've just slowed the video down here. We've got the crocodile forceps on this. Because of the nature of that skin, it's going to really hold tightly, so it means we can hold onto it and get a really good pull at this then. Now, I showed you the crocodile forceps a few videos back, so you've got an idea of how big those jaws are there. Now you can see we've managed to clear some of the edge here. I've just brought the St. Bart's hook in here because it is quite tough material. I'm hoping that we can get a grip behind it and pull it forwards. But as you saw, the St. Bart's hook, it's that tough, it just kind of scraped over the top. It didn't bed in. So I'm using the Jobson horn upside down now just to lift these kind of flaps away, just to pull around the edges, using it as almost like a range marker to try and work out how far in we go with this, this material now. Just slowly pulling this away. You can see we've lifted that flap up now. I'm just trying to see if we can, now we've detached it, whether we could pull it forwards. But it's all holding together really tightly. There we are. We've pulled another layer of skin down. I'm trying to get behind it just to bring this forward. Just using the crocodile forceps again now to get a good grip on this piece of skin. Just slowing this down. Now look at, as we pull this, you'll see the skin concertina. It all kind of unfolds and pulls backwards. There we are. Can you see that coming away there? And it's actually pulled the next layer forward. Look how long that strip of dry skin is. Can you see how far that's come away? So we're just going to pull this next section now. Going to try and get a really good grip on this. There we are, and look at the debris and the skin. There's more skin getting pulled through. You can see where this is actually originated on that right-hand side of the canal wall. So that cavity goes all the way around to this right-hand side as well. There we are, pulling that away. When we talk about, you've seen obviously a lot of debris getting pulled away here. This dry skin, it doesn't hurt. I just saw one of the comments pop up asking, does it hurt? And it's basically, Jacqueline just commented asking, does this hurt? It doesn't hurt because it's dry skin. It's not really got any nerve endings in there. So it's coming away quite nicely. Just lifting now from the side again. I'm trying, what we've done is removed some of the looser debris, but this other material left is actually really firmly attached to the side of the canal wall. I'm trying to get a good pinch. Watch this now as we pull down. See, as it's pulling from the cavity, you see that just start to drop from the attic portion of the canal there. So I'm just going to try and put the leading edge of the forceps in there. Just start to cross the camera and the forceps over just ever so slightly. There we are. Keep watching. This gentleman was sat in the chair for this, altogether for probably about 30 minutes. Obviously, we've condensed this down, so it gives you some idea of how long the patient was sat there. But what an absolute star! He was so good. You can see now we're just trying to get behind it, lift this portion out, and push it across. The feeling the patient gets from this is more of a sort of a pulling sensation more than anything else, because there's, I know we talk about the sensitivity of the canal wall, but obviously when a lot of that's been cut away, most of the time you feel just pulling, and you'll feel it actually pulling against the skin a little bit, but it's not uncomfortable. So we're trying to get a good grip here. There we are, just holding on to this section. As we pull across now to the right, can you see everything starting to move? You can see it's drawing a larger piece out there. It's all holding together really nicely. So we've managed to get a lot of debris from that cavity in one piece. Look at it all held together and bound together there. It's quite a large piece. So actually drop this top section down slightly. So we're going to keep using the crocodile forceps. See if we can get a grip. I'm trying to get a good grip there, but you can see it's difficult. It's just the angle of the skin has gone away from you and it's quite wide, so it's difficult to get the forceps over when the skin's like this because it's pushing away. So I'm going to aim for the darker, harder piece of skin behind. We pull that down, slowing this down again. Look, we're taking another section away there. Still connected to what's coming out behind as well. You can see it's really, really pulling this away. So let's see if we can, we've started to clear some of that left-hand cavity now. There's a lot more kind of up in the left-hand corner there and a cross tuck behind on the right-hand side. So you can start to see where the surgery's come through now, because obviously the bottom right-hand corner, that's the eardrum there. So all this to the left-hand side is actually the cavity there. Slowly using the side of the Jobson horn now just to try and pull down. Looking for any looser sections we can use there to draw out. You can see how hard the actual Jobson was flicking off the top of that skin. You can see there, it's just pulling across. So I'm going to try and lift again. So turn the Jobson horn upside down. Use the angled end of the Jobson horn just to lift away from the side there. Pull more into the center. So if you imagine you've got the edge of the ear canal there and the cavity's back here. So you've got to kind of work around the corner, which is quite difficult to do. So we've lifted that bottom section. We're going to get a good grip on this now with the crocodile forceps. That's taken that bottom piece of dry skin away. But we've still got this piece to the left-hand side that needs to come away. It's just folding into the ear canal at the moment. Laura just said, could a doctor have seen this when looking at it? Yes, you would have seen this. This is why it's always really important when you look at the ear canal to look all the way around the canal, because they can get missed sometimes, because if you're not looking for it, or if you don't angle the oroscope enough to be able to look in there, you may well just appear at first glance to be quite an ordinary ear canal. But it's not until you start to look around the corner that you start to see it. Now we've got a good grip on that section. Look how that folded forwards then. It pulled more from around the back of that, more from around the back of the little section there in the cavity. Just trying to get a hold of this bit. See if we can get a good grip on this front section here. And as we pull, you saw it pull another little bit down. There's more still in there, you see. Okay, just trying to hold on to this edge now. We've got a good grip on that section. Watch as we pull this across to the right. Can you start to see everything just pulling down and from that cavity there? You can see now we've found the edge of it. We've just got an edge. So if we can get the forceps either side of this and get a really good grip, look at that pulling down there now. We've almost got it. There we are. You can just see it just fold a little bit more from the top. It's really starting to loosen now. So if we can get a good grip, a substantial grip on here. There we go. Look at that folding in. Yeah, this is something that people are going to need to have done quite regularly with this mastoid cavity. Look at that coming away. We've really pulled nearly everything out of that left-hand corner there. It's really drawing down the canal. It's pulled out of the cavity. It's moving forwards. Luckily, this is all staying together really, really nicely. We'll just need to get a really good grip. And you are pulling quite hard against this skin. You've got quite dried skin that's really wedged into that cavity. So you have to pull quite hard to draw this down. There we are. This is coming away. You can see the size of this chunk. And all this, don't forget, was sitting just out of view on the left-hand side. That's all we saw was the leading edge, but all of that was sitting into that cavity there on the left. There you go. You can see that cavity now. We've got this You've got a little material there at the front. You can see you've got a flap of skin sitting just in front of the eardrum, and then you've got this ridge there. Now the ridge is actually where the ear canal should have ended. But what we can see now is, look, as we peel this, you've still got more in this attic region at the top, dropping down into the right-hand side there. So we've got to get a good grip on this. As we pull it down, watch what happens. You'll start to see more of the skin coming around. It's that asked, would irrigation not work well for something like this? It really wouldn't. You really don't want to get this ear wet. You want to keep it as dry as you possibly can. Imagine you've got that cavity there, water will pool there. You run a higher risk of infection. Obviously, the reason they've had this surgery done is because there was obviously an infection that was caused in the first place, a repeated infection there. So we can see we've got this flap of skin now. When we lift this up, excuse me, sorry, I'm a bit dry. When we lift this up, you'll start to see you'll start to see the actual eardrum behind there as well, and it's got a lot of scarring on it. So I got a sip of water, and we're just starting to pull it down now from the top. It's difficult to get the grip there on the forceps because the skin is flat backwards, you see. So we're trying to go in and grab it with the forceps, but can't quite get the grip there. Oh, let's have a little look. Gary just asked how many years of wax is in here. It's difficult to say. This gentleman hasn't had this cleaned out for a couple of years, so it was difficult to say how much exactly, but you can see now we've got a good grip. I've gone in with the St. Bart's hook to get behind that flap of skin, draw out the excess skin that's around the corner, bring it out, so it makes it a bit easier for us to get grips on this. Okay, so that's pulling down really nicely. There we go. You can see it's really starting to feed around the corner. Just trying to get the top of the crocodile forceps in there to try and grab this and bring it down. There we are. It's just starting to get that skin coming away. Now you'll see that the little flap of dry skin there just at the bottom. Just lifting very slowly. There we go. We're trying to get a grip on this. Obviously, I don't want to use the forceps down this deep because it is right next to the eardrum. So I'm trying to use the suction as much as I possibly can. Even if I can just bring this away from the eardrum so we can then angle on for the suction and grab that in a second. I know loads of you are asking questions. I'm sorry, I'm trying to keep up with this and answer the questions at the same time. What I'll do is if I comment on this, I'll answer all your questions afterwards. There we are. Look at that as it unraveled this long strip of skin that was sitting just in front of the eardrum. Now we can see the scarring on the eardrum there. Using the St. Bart's hook now, I'm trying to maneuver this piece of skin here just to bring it into view so I can get a good grip on that with the forceps. Really pulling it around the corner, lifting it back up so that takes it away from the skin so we can just get on there with the forceps now. There we are. Look at this as it comes away. Long piece of dry. Look, it's still coming. There we are. So all that was hidden in that cavity there. And there we are. There's it. The eardrum is actually to the bottom half of that screen there. But you can see it all around the side. So we've got the larger chunks there. These kind of chunks around about the 2 to 3 centimeter mark was one of the larger pieces we took away. Look at all the really light material in there. That long strip of skin you could see there at the end as well. So lots and lots of bits coming away there, and some quite substantial pieces as well. This gent was an absolute diamond. He did so well. He was doing really well with everything that was going on there. He's just an absolute trooper, And there we are. So you can see we removed 7.5 inches, 20 centimeters. That is the most wax I've ever removed. And you know, the gentleman was absolutely amazing. He was so good to sit through what he did. Although it's not painful, you do get this sort of strange pulling sensations. You pull it out, but it's not uncomfortable. And the gentleman was really. Was the patient relieved after this, Suzanne? Yes, he was. He was relieved. Yeah, I think he was quite shocked as to how much came out of the ear as well. You know, and I think we didn't expect quite as much as that to come out. Oh, what a lovely guy though! What an absolute trooper! What a star! Right, so. that's the video part done. I'm sorry if I was jumping back and forth between questions. It was really difficult to keep tabs on your questions and answer them and commentate at the same time. So this is a bit where we kind of open the floor for you guys. So obviously you're going to have a lot of questions coming up from what you've just seen. So by all means, if you've got a question, pop it into the comment section like this one. Andy Livingood said, wouldn't this have irritated the patient long before there was that much? The patient hadn't really noticed any issue. If I'm being really honest, the patient came through with a problem with their other ear, not with this one. So we hadn't really noticed any issues with this particular ear. Now, sometimes, obviously, if that material gets infected, yes, then that's going to irritate you and you are going to feel like you need to come through and get that done. But most of the time, because it's this kind of dry skin and debris there, you don't really feel it in there. Any treatment needed to the ear after this removal, or will the ear recover itself? The ear will recover itself. You don't really need any treatment after this, apart from sort of regular suctioning, regular cleaning, because it just stops and minimizes the risk of any infection taking hold and leaving any debris behind in there, really. Let's have a little look. Have we got another question? Well, lots of people say just lots and lots of wax. Have we got any more questions coming through? Let's have a little look. That must have felt good, yeah. What star of patient? Yes, absolute star. What an absolute diamond the gentleman was, and such a lovely, lovely guy as well. Please thanks the gentleman for us all. Loads of people saying thank the gentleman for us all. That was amazing. I think he is watching, so I'm sure he's getting all these thanks as they're popping up on here as well. Is that a common surgery? It's more of a substantial surgery than most of the surgeries you have done on your ear. I mean, if you get mastoiditis, which is where you get the actual infection into the bone, it's really incredibly painful. It's really sensitive to touch, and it would be repeated infections, but you have to get that out, and the only way to do that, unfortunately, if you've tried antibiotics, is using surgery to do that then. So Kim, fab video, you have used lots of instruments. Do you have a favorite one? No, as you know, I do like microsuction. I do like the Zollner tubes. I'm quite fond of a skin peel though, so I do quite like the fine ends for using that as well. Jobson Horn's probably one of my favorites. I do like them all really, because they've all got uses, and it's just, if you can get that patient hearing better and get the satisfaction, get it as clean as you possibly can, they're all fab. Let's have a little look, see if we get another question. Jaleesa, I think it's Jaleesa Morrison. How can I do this for a living? It's a degree course. If you're here in the UK, you do a degree course in audiology. There's lots of different providers, lots of different universities do that. It's a 4-year degree course, so it's a fantastic career. If you're really thinking about a career to get into and it's taking some interest, go for it. It's a fabulous career to do, and you help so many people. It's such a rewarding job as well. It's absolutely fantastic. I love it. I love my job. Roberta Dweck, how about the other ear? The other ear, there was a very small amount of wax in there, quite deep against the eardrum. It was cleaned out really, really quickly. It just would have taken seconds to show that. We just edited the big one in for you to have a look at. Alison Hawkins, how do you know when you need your ears done? I have mine irrigated, but it doesn't last long. Sometimes people normally notice things like they'll get sensations in their ears, their hearing may well be affected. Sometimes people get discomfort when they lay on their ears. They get a referred pain down into here as well. I think if you're basically the long and short answer is if you really think that you may have something going on there, go along, see an audiologist. If you can't see an audiologist, go along to your GP, get them to take a look. We do find sometimes with irrigation, obviously there is a risk to perforation to the eardrum. So when people are getting their ears irrigated, people tend to be a little bit more cautious when irrigating. So because they're afraid of doing damage to the eardrum or perforating the eardrum. So sometimes things do get left behind. So if you have to have it done quite regularly, I would pop along to an audiologist, get them to take a look in there and see whether they can do anything for you. Lara Nellemans, does a mastoidectomy cause changes in hearing? Yes, it can cause reduction in hearing. If you imagine your ear canal is a lovely tube that has a natural resonance, so it's basically going to amplify certain sounds or add a little bit of amplification to certain frequencies. When you have a mastoidectomy done like that, it opens up the ear canal, you lose some of that intensity. So you will, and a lot of the time, because it goes along with scarring to the eardrum, with repeated infections that have happened in the past, you can then get this reduced hearing. A lot of the time it's what they call a conductive hearing loss, or a problem with the sound getting transmitted to the inner part of the ear that causes that problem for you then. Yeah.
question.
Zimmy said, hello, Mr. Barber. What is the weirdest thing you've ever found in an ear? I get asked this one a lot. People also ask me if I get bugs, if I've ever seen bugs. I've never seen anything living in an ear. When I used to work in pediatrics, then in children's ears, you see all sorts. Kids love putting stuff in their ears. I've seen Play-Doh, which is always one of the weirdest things to look at, because especially if it's pink or red Play-Doh, because you think something, there's something really wrong going on in that ear. I've seen probably the weirdest thing is a piece of glass was the weirdest thing, and that was quite a young child, little glass shard that was pressing against the eardrum, which was causing quite a bit of discomfort. So yeah, that was probably the strangest thing I've ever seen. Let's have a little look. Have we got any more? Sadie, when I use earbuds, little pieces of skin come off into them. Should I see an audiologist? When you use an earbud, what you're doing is effectively you're stripping away the top layer. Now, this skin in the ear canal is quite common to get little dry patches of skin. That's quite normal coming away. But what you may find is by using the earbud, when you're moving that around the canal, you're actually stripping the top layer of oil that's secreted in the canal, and that it tends to dry the ear canal out a little bit as well. So you are probably more likely to get these little bits of dry skin and dry patches in there. So instead of using the cotton bud, try using a little bit of olive oil. Once about every 2 or 3 weeks, not much, just enough just to moisturize the canal wall, and that should cut down on that dry skin you're finding in your ear canal then. Let's have a little look. So, well, nice job. Thank you very much, Sharon. Yeah, it was a tough one, but good. Let's have a little look. What else have we got? Oh, somebody's saying happy birthday, Mrs. B. It's Mrs. B's birthday on Wednesday. Mrs. B.
21 again.
21 for the 4th time.
94.
Okay. I missed that one. Yolanda Morales. Who is the farthest patient? The farthest patient. Somebody had stopped off here from Australia. They were on a world tour and they stopped off in the UK, literally stopped off in the UK, came to us, had their ears done, and then jetted back off. So I think they had a few ear problems in the last country they visited. Their partner, who was still in Australia, had researched it, found us, said, you've got to go and see this guy. And they'd come here, got their ears done, and gone again. So that's the furthest someone's gone. We did actually have someone today from up near Birmingham. We've had a couple of London, Ireland, a few places. Okay, my dad loves you. His name is Rob. Please say hi to him. Hi, Rob. My dad's called Rob as well, so there we are. Let's have a little look. Oh, what's this one? Diana McDowell, when you encounter something like this, what do you say as you're removing it? Obviously, you can't say anything to upset the patient. I'm always quite honest with the patient because I find patients respond much, much better if you're really honest and upfront with them. So obviously, when I'm taking this out, I will say, there's a lot in there. Sometimes if the moment is right, we'll have a little laugh and a joke about it. I think we both did say at the end of this, it's a shame that Wetherspoons is still shut because we could both do with a drink after that one. But it was, we do talk about what's going on. I try and inform the patient as to what I'm doing, especially if you're doing a lot in there. I always try to just check in with them, make sure they're okay, just explain what I'm doing next, show them the tools before I use them. So I'm always quite honest with what we're doing and upfront with it. So. Karen Atkins, have you ever had your own ears done? I have. I had wax problems when I was about 18, and I had my ear syringe then. And on all the training courses, I'm usually one of the guinea pigs that goes in to volunteer to have their ears done. And Peter did mine, actually, a couple of months back as well, just as a bit of a practice run. So, Gail Sullivan, me and the hubby are going glamping next year. And I said we're going to Wales just so I can come and see you both. Love you too. Oh, thank you, Gail. Wales is a fab country. If you get the chance to visit it is such a beautiful country. Come along and see us over here in Wales. If you're ever in the area and you watch the YouTube channel, pop in, say hi. You're more than welcome to. Carol Westwood, do you feel a buildup of wax causes tinnitus? It can sometimes exacerbate tinnitus symptoms because when the ear canal gets quite blocked, or even if you have a piece of wax that maybe is resting against the eardrum, then what can happen sometimes is it can just dampen the sound. And if you've ever experienced tinnitus, it's much, much worse when you're in a quieter environment. So if it's dampening the sound and causing a reduction in hearing, then what will happen then is you will be more acutely aware of your tinnitus as well. Obviously, if you do suffer with tinnitus and you've never been along to chat to anybody, always go along to see your audiologist. Always worth a little chat and see what's going on. Kim Mason, is there an age limit? How old do you have to be to have wax removed? Happy birthday, Mrs. B.
Thank you.
So basically, there's no upper age limit. I mean, we get people coming through 100 years old. I do tend to only try and see older children because of the size and shape of the ear canal, and because they're more likely to sit still to have the procedure done. So I tend to, I have suctioned young children, but I tend to prefer to see slightly older children to do it. Oh gosh, right, okay. This is another one I get asked a lot. What does it smell like? Do you know, wax doesn't really smell. People always think it's going to smell really strange. Obviously, if there's infection in there, then it's quite a pungent smell, and you'll smell that being quite close to the patient. But most of the time, earwax doesn't smell of anything at all. To be honest, there's no smell whatsoever. No smell whatsoever. Yeah, it's not a bad job. It doesn't bother me whatsoever. I know that some people, it makes them feel nauseous and things like that when they take wax out, or if they look at. Not for me. It's all part and parcel of that patient's experience, really. Okay, Gareth, I've noticed in a few other videos you refer patients to ear, nose, and throat specialists after you've extracted their wax. What would they do that differs to you as an audiologist? As an audiologist here in the UK, we have certain boundaries. We're not allowed to do certain things such as surgeries. And we can refer back to a medical practitioner, so we can refer to your doctor. We can't, although we can diagnose as such, we can see what's going on, we can suggest what's going on. To get an official diagnosis for certainly some of these ear, nose, and throat problems, you would need to see the ear, nose, and throat consultant. That is their specialty. That's what they do. We can look at anything ear, hearing, balance, sometimes tinnitus related as well. But anything out of that remit tends to have to go through to see a more specialized doctor, which is where ear, nose, and throat come in. Hope that answers your question. Seen that one. Super Skin and Hair Care. Hi, Super Skin and Hair Care. Since you all work together and are married, does it take the romance out of the rest? What did you say, Mrs. B?
No, you're very
Mrs.
romantic.
B said, no, I'm very romantic, apparently. No,
you are very romantic.
We
make time.
We make time for one another. We really do. I mean, tonight, obviously, we're both here in clinic at 9 o'clock. Was it 9:30? But yeah, we try and make as much time as we possibly can for one another. Yeah.
Put you on the spot there.
You did put me on the spot there. Mrs. B's controlling the questions that are coming up. I've got no control over this. So I don't know what she's going to pop up. Laurie Jones, your videos are the highlights of everything. Oh, thank you, Laurie Jones. Thank you. We're really trying to keep to this Monday, Wednesday, Friday format. The only thing I've found at the moment is I've got a real 50-50 split with people at the moment between the old format, just the voiceover without little me in the corner, and the new format with little me in the corner. So I think what I'm going to do, I'm going to go back to the old voiceover format because people are saying, oh, I missed that one. And I think what we'll do is if we get something quite unusual or something that maybe needs a little bit more explanation, then we'll do the new format for that one, just because I can go through a bit more explanation with you, if that's okay with you guys. You are going to start seeing some other videos popping up, but I'll go into that in a bit more detail a bit later on. Do you have a page in Instagram? Yes, we do have a page on Instagram. We have two. We have a Audiology Associates page,
number 89 by the lake,
which is called Audiology Associates.
Yeah.
And we also have, if you want, but Mrs. B does a page which just shows some of the background of our house and stuff, because we're doing bits of the house and stuff, which is called Number 89 by the Lake. So if you want a bit of a nose at what we do when we're not here, check that one out. That's right. Mrs. B would love to get a few more followers on Instagram.
Always.
There you go. Kathy Beckford, how do you work with patients who have sensitive ears? They feel things tickling in their ears. Do you use more suction? Some patients are really sensitive, really, really sensitive. And I always tell the patient before we start, if it's uncomfortable, if you need me to stop at any point, please tell me before we do the procedure, okay? We explain all the things, all the sort of limitations of what we're going to do, any possible side effects beforehand. So we do get some patients who ask us to stop because their ear canals are quite sensitive. We try and avoid the canal walls in that case as much as we possibly can, because if they are really, really sensitive, then that could be quite uncomfortable for the patient. Or we may switch tools, move to a different area. So yeah, patients will always tell us if they're not feeling 100%. Let's have a little look. How are you coping with COVID? Oh my goodness, yes, COVID. Yeah, we personally have had a bit of a tough time with COVID because we lost a few family members through COVID. it was difficult not being in work. The thing is, when you come into this profession, you come into the profession because you genuinely want to help people, and when you can't do that, it's so frustrating. And we all our patients are like family, and when you got people were ringing us and say, look, can you please help, and we couldn't. It was really tough. I'm so glad to be back open. We have a lot of sort of PPE, lots of stringent procedures now to keep both us and our patients and our staff safe. So there's a lot more things we need to do, and it was quite a steep learning curve, but we're there now, and luckily we're getting lots and lots of patients coming through. I think we're fully booked up for about a week in advance now, which is absolutely fantastic. So look, fingers crossed, we're clearing our backlog, we're getting through all the people in, and it's all working out well for us. The switchblade kiss, is there any way to clean your ears at home? Yes, if you have a Q-tip, snap it in half and throw it in the bin, all right? Because what I would do, most ears are self-cleaning, and they self-clean really, really well. Obviously, what you see on the channel here tends to be this kind of more extreme cases, but for every one person we see here, there are 30 people who don't need to come to clinic. So what you'll find is we do, if you just let them clean themselves. If you're in a bath or a shower, just let a little bit of water trickle in, let it trickle back out again. That will wash a lot of it out. Most of the wax will come out when you're sleeping, when you're drying, with baths and showers. If it doesn't, and you just want a little bit of a helping hand, use a little bit of olive oil. That's one of the best things you can use. It really helps to soften the ear canal walls, keep the skin nice and soft and supple. It keeps the wax soft and stops it from getting sticky, and it'll keep migrating out that way. Gina Lambert, how does cleaning my ears make me cough? This is your Arnold's reflex. There's a cough reflex, basically. It's about halfway down your ear canal in most cases. If you touch on the canal wall, you get a really bad tickle at the back of your throat, and you can't help but cough. There's a few funny reflexes. There are some that link your eye to your eardrum and bits and pieces of that. But Arnold's reflex is the one we come across probably most often. As you're extracting the wax out, the wax may just brush against that particular portion of the ear canal wall, and the patient can't help but cough. Yeah, can't help but cough.
Loads of people on here asking about your beard and what I think about it.
Oh, Beardgate, yes. Yeah, I've had to shave my beard. Lots of people asking, where's the beard gone? I had to shave my beard off because of the face protection we use. If you've got facial hair, especially a lot of facial hair, what happens is the mask doesn't get a really good seal. And obviously, we're trying to keep both myself and my patients safe. So the beard had to go. I miss it so much.
Not as much as me.
Oh, Mrs. B misses it even more than I do. Mrs. B has only ever known me with a beard. So I clean shaven once. And she cried.
I don't like it.
Yeah, and my son cried. So yeah, they don't like it without a beard. It'll come back as soon as it's safe to do so, because trust me, nobody wants to see this face unless it's covered with hair.
Oh, I don't see that.
Beardgate, yes. Can you tell if a patient has used cotton? Yes. As about the amount of times we've looked at patients' ears and they've used a cotton bud and jammed that in there. And you say, have you ever used? No, never used. Don't use cotton buds. But you can see by the shape of the wax what tends to happen if you use a cotton bud. The center, if you imagine this is a wall of wax, when you push a cotton bud in, it does this and it bends around like that. So you end up with a really kind of like a cup shape to the wax with a dent in the center, and that usually means that they've been using cotton buds.
The feed has been taken over by the beard.
Everyone's talking about my beard now. I know. Yeah, I miss it. Do you know what? I think it's when it comes back, it's going to look like Father Christmas. It's going to be completely grey when it does come back. Oh, what causes the sound of water sloshing behind your eardrums? Okay, you can get the space behind your eardrums. Get the big ear out. Oh, my eardrum's collapsed. Hang on a sec. Let's pull my eardrum. There we are. So the space behind your eardrum, which is just there, it's called your middle ear space. Okay, now you've got your eardrum on one side, and behind that then you've got your three little bones in the middle part of the ear. Now that space should be filled with air. Now what happens sometimes, we produce a thin almost like a sinus kind of fluid in there, which helps to, every time we yawn or swallow or chew, there's a tube called eustachian tube, which connects the middle ear space to the back of the throat. So every time you yawn or swallow or chew, fluid comes down, air goes in. So the fluid washes anything that might be creeping up from the back of your throat into that space, like a bacteria or something like that. So basically that washes out. But sometimes what can happen, especially in the winter months, is the tube can't open and shut as well. So what you get then is almost like a little layer of a fluid that sits behind the eardrum. So you may well hear that moving around in there. Some people refer to it as well. You can get a kind of rumbling sensation, but that's more to do with little muscles that sit behind your eardrum and onto the ossicles, just kind of almost going into spasm, which just causes a vibration through the eardrum, which is like that rumbling sound that people hear, or people describe it as like insect wings in their ears. A really strange sensation. Okay, how are we doing? Oh, there's one there. I'm sorry. Right. Okay. What do you think about ear candling? Ear candling. Okay, it's one of those things. It's been around for a very long time. So I've got some patients who absolutely swear by them, and I've got other patients who've said they're absolutely rubbish. Now, I've seen lots and lots of different research on ear candling. Most of what I've seen points to the fact they don't really work. What you see inside the ear candle is not actually wax. It's the wax of the candle melted and dropping down inside, which gives it this kind of darker appearance. I've seen quite a few YouTube videos where people have looked at it and done it in patients' ears, out of patients' ears, and they've got very similar results inside the candle. So I personally don't think it works very well. I've had a few people who have come through and said, I've tried, I've my ear candle. It didn't seem to make any difference whatsoever. Also see, Carl Shearer keeps asking about how an autistic person would approach ear cleaning. I'm quite curious too. Any tips? I mean, if you can tolerate having that little bit of olive oil in there, don't forget the ear will self-clean. So in the majority of cases, it will. Calcium, there you go. In the majority of cases, that will actually expel the wax itself without you having to touch it. So what I would say is, if you can tolerate a little bit of olive oil in there, maybe every 2 or 3 weeks, great, that will really help. If you can't tolerate it, that wax should migrate out on its own. Okay, should be coming away on its own without you having to touch it at all. Okay, so certainly, if you can't tolerate anything in there, just leave it well alone. We have seen a few patients, a few people on the autistic spectrum, and we've cleared their ears quite well. So yeah, it's worked out really well. Most of the time, it's mostly the preparation, preparing your patient before they come in, making sure they know exactly what we're going to do, exactly what tools we're going to use. We do direct a lot of people to the YouTube channel so they can see what's going on inside the ear. As with anything, I know myself, if I'm a patient having to have something done, then the more I know about what's coming, the more relaxed I feel going into that appointment. So that tends to work for us as well. Does vertigo have anything to do with wax? If we're talking about, when we talk about vertigo, it's quite a broad spectrum. When we talk about vertigo itself, that's the room spinning. Like you've had one too many and the room is doing this, then that kind of problem wouldn't be a wax problem normally. It would usually be related to either an inner ear balance disorder. You can get little viruses that can affect it. Even sometimes extreme cases of middle ear effusion or very retracted or very reduced middle ear pressure can cause those problems. What we do find quite often with wax is that people say they feel a bit disjointed from their surroundings. So not so much dizzy, but they do feel a little bit off kilter, and that's all to do with a lot of the time the way we orientate ourselves within a listening environment. So our brain is really good at being able to sense differences in sound levels and sound intensity and the speed of sound hitting your ears. So it's how we orientate ourselves within that environment. Especially if you've got one ear that's very blocked up with wax, that whole system gets thrown. So it's really, really difficult then to really kind of work out where sound is coming from, which can feel quite disorientating. That's more the type of sensation you get with wax. What makes the ear feel wet inside a lot? You can get very wet wax. I mean, some people produce a very soft, wet feeling of wax. Sometimes what people will feel as a wet or a tickling sensation can be dry ear canals. The skin in the ear. Imagine your ear canal. your temporomandibular joint, so your jaw hinge, if you like, back here, when that moves, it does this. It doesn't sort of rock in a socket. It kind of moves back and forth. So what effect that has is it moves the ear canal, so it flexes like this. So if you've got particularly dry skin in there, then with that flexing, you'll feel it pulling. It can give the sensation of something moving or something feeling wet in there. But if you're getting wetness, especially if there's an odor to it, definitely go along and speak to your GP. Tonna Hayes, how often would you recommend a person getting their ears clean, and how do you clean them? I would say if you're somebody, some people produce very little wax and there's hardly anything coming out at all. If that's the case, then you may go years between having your ears cleaned out. We tend to say to people, if they've been through once, we send a reminder in about 12 months. 12 months tends to be about the average length of time in between wax cleaning appointments for us. Bev Hodgson, have any patients ever requested that they be sedated before they go into their ears with tools? No. I think because patients, when they come to us, the clerking staff are really, really good at managing the patient's expectations about what's going to happen when they come through. I also try, if we know we've got a nervous patient, we always allow that patient a little bit longer. In fairness, the ladies who clerk my appointments will make notes on there just to say that the patient's nervous. I really explain everything. I put the suction tube on their hands. They get to feel how strong the suction is. We put it near their ear so they get to know the sound before we even entertain the idea of going into their ears. And it's always explain what you're doing before you do it. There's nothing worse than just sort of jumping into somebody's ears to do stuff if they don't know what's coming. It's going to make them even more nervous. And sometimes I will say to the patient, look, do you want me to talk you through this whilst I'm doing it, so they know exactly what's happening? But yeah, we've had some very, very nervous patients over the years, but luckily no one's had to be sedated. Doris Bezerra, my husband hates the hairs in his ears and wants them out. Is that bad for him? No, I mean the hairs on the outer part of your ears called cilla. Now they're very, very fine. Now they're the ones that do the job of stopping larger bits of debris getting inside the ears, dust, that kind of thing. The hairs that you see on the outer part of the ears, which happens to us all, unfortunately, they don't really do anything. They're just hairs sprouting out where they shouldn't be sprouting out. So you can cut those away quite happily. But the little tiny cilla that's deeper inside the ear, you can leave those alone. And most of the time, when you talk about trimming your hair, you talk about the thicker stuff on the outside. Teresa King, are people genetically predisposed to earwax buildup? I don't know anyone who has been to an audiologist and had done what you do in the videos. Some people are more predisposed to it, and when we talk about certainly you're talking like people from Asian countries, they produce a much drier type of earwax, so you end up with this, so it tends to kind of stick to the canal and become quite hard sometimes. So you do get these differences between sort of different groups of people as well. And it's some people produce a lot, some people produce hardly anything at all. And it's like I said a few questions ago, for every one person we see, there are probably 50, 100 people out there that don't need to come through the clinic. And I've looked in people's ears when they come through, and some people have not a single bit of wax. You get other patients have to have it done every 4 weeks. It's such a variable thing. We got another one. Where can I buy the olive oil that you use, Tal? You can get it from Amazon. We use an olive oil called Earol. The reason we use that one is because it has a spray adapter on the top, which means it's really easy to applicate. It's really good stuff. We use that in all our clinics. What you do is you pop the little nozzle on the outer part of the ear, give it one spray, and that is your dose. So it's a metered dose as well. And also the olive oil inside it will stay good for probably about 2 years. Whereas if you get the screw top with a pipette, that has to be thrown away after 30 days. So yeah, you can get it from Amazon. In the description below, there are some links to our Amazon affiliate, so you can get the Earol from there. So it'll take you straight to there if you want to click on those as well. Can you recommend anything for use with psoriasis in the ears? Yeah, this is a really tough one. I've seen some people use ear calm, and that tends to work for quite a lot of people. Strangely, this question came up on an audiology forum the other day, and ear calm seems to be one of those things that people tend to use a lot for psoriasis. It just depends on whether you can kind of tolerate having that blunged up feeling, because a lot of people with psoriasis, they tend to have that slightly narrow ear canals just because it is a little bit more aggravated, but the ear calm usually helps to kind of spread things out a little bit, widen the canal out a little bit. My son through his all screams and cries at the thought of blowing his nose because he says it hurts his ears. Is that a common thing? Yes, it is. as many of you know, my background's in pediatrics, so there's a really common problem that children get usually up to about age 8 or 9, where the eustachian tube we were talking about earlier. So this tube, where are we? There we are. Let's come on this way. So this tube here, okay, this is called eustachian tube. So this is what we use to equalize our pressure behind the ears. Now in adults, that tube is like a sort of this sort of angle, so it's quite straight. In children, especially younger children up to about age, the 3 and under, the tube is very flat, so they find it very difficult to equalize pressure. And sometimes what they'll do is when they blow their nose, what you're causing is a resistance to the airflow. So you do encourage air to pop in through that tube to behind the eardrum. So you'll get this sensation of popping, squeaking, that kind of thing. And if it all rushes in one go, it can, especially if you're a younger child, it can feel quite strange. So it is a really, really odd, strange sensation. Yeah. Have you ever cleaned Mrs. B's ears? No. I've never had to do it. No, I had to do my son's the other day, but I've never done Mrs. B. Mrs. B's ears are squeaky clean. They are perfect, as is she.
Oh my goodness, you're too funny.
I recently purchased an otoscope camera that connects to my phone. Thanks to you, so exciting. Oh, I know. I've seen lots of these around at the moment. This seems to be quite a big thing. Obviously, what we use is obviously a custom made for the job. But I've seen a lot of these little tiny sort of endoscopes and little oroscopes that connect to iPhones. They seem to be becoming really, really popular. I'm half tempted to get a couple and do a video on it and see what they come out like. Maybe that's an idea for a future video. We might have to do that one, and maybe ear candling as well, because that comes up a lot. We'll see. We'll see. Oh, I think I just saw my lovely sister-in-law pop up there. Any suggestions for keeping ears cleaned when I shower? If I get water inside, it causes massive infections that then cause massive pain. Oh, bless you. Okay, what I would do in your case is I would try and keep those ears as dry as you possibly can. It may even be what you can get something called swim putty, which is like a moldable silicone that you can pop on the outer part of your ear that'll keep your ears really dry. The thing is, if you can stop the infection and the cause of the infection, which is the water getting into your ears, then your ears are more likely to clean themselves. So it's going to be really difficult, obviously, for someone who suffers with these infections to do that. But try the swim putty first. You can either get a moldable beeswax or a moldable silicone. They cost, I think it's less than £10 each. So get both and try whichever one works for you. If that doesn't work for you, or you find they keep falling out, get a set of swim plugs made up. You can get, if you see your audiologist, you can get a custom set of swim plugs which will stop any water from going in, because they are custom made to your shape of your ear, and they form a really effective barrier against water. Yeah, try that. I don't know the drink, I'm talking so much. Wow, so many questions. I can see so many things coming through.
Somebody's just asked, could you do a video of the history of earwax removal?
Ooh, that'd be an interesting one. A history of earwax removal. We could look into that. Yeah, there's a couple of ideas we've got bouncing around at the moment, and I love it when you guys give me ideas for doing stuff, because it helps me to kind of push the channel in the right direction, which keeps you guys watching it. But yeah, if you've got any ideas, pop it up to. Couple goals these two. I know, we're amazing.
You're absolute nutter.
Okay, why does water in the ear cause infections? Sometimes, especially if you've got very dry, some people are very prone to infections anyway. If you imagine you get water in there, it takes little bits of bacteria in with it as well that we've washed off our bodies, and if you're in the bath or shower and stuff like that. Your ear then is warm, it's moist, it's a perfect breeding ground for infection. So if you have a slight propensity to infections, getting water in there does tend to trigger them off quite a bit. Sometimes if the skin of the ear canal wall gets a little bit dry, you can get these little sort of micro fissures in the top layer of skin as well. Water sits in there and it just causes infection. So that's the reason for that one. Oh my goodness, so many questions. Mummy's lying. Hello, Mummy's lying. My 11-year-old has tinnitus in both ears. Should he see an ENT? Is there anything that can be done? I think I would definitely go along and get some advice on that one. You could be, there could be lots and lots of different reasons for it, some of which there may be something they can do to try and help. But if you've got tinnitus, definitely go and get yourself checked over just to make sure everything is okay, and get some advice. There is this big myth out there that tinnitus can't be cured, which I think is a bit too of a dramatic sort of term for it. I think that there are lots of things that you can do to help with your tinnitus and make it more manageable for you. And here in the UK, NHS is a fantastic resource for that. Your local GP is a fantastic resource. The British Tinnitus Association is also another great one to look at. So there's lots and lots of advice out there, okay? And don't be put off. Go and get some advice, because some things can be helped. Some things can be helped. How did audiologists clean ears back in the day when there was no camera or light you could use to see in the ear? Interestingly, there is records of, like we use the Jobson horn. There are tools that look almost identical to that, which are hundreds and hundreds of years old. So ear cleaning's been around for a very, very long time. I once watched a program about a tribe somewhere, I think it was in the Amazon somewhere, and they were using a little grub that they popped into their ear, which kind of churned up the earwax and kicked it out the other side. So I think that people have developed lots and lots of different tools to do this, and ear cleaning's been around for hundreds and hundreds of years. Yeah. Okay, one last try to post my question. Okay, I have a lot of clicking noises in the ear, especially when I'm swallowing. I've had this for more than 5 years now. Should I see a doctor because of this? It sounds like your eustachian tube is opening. When you swallow, yawn, chew, your eustachian tube opens and shuts to equalize pressure, and some people can hear that as a clicking or popping. That's perfectly normal. That's absolutely fine. It doesn't mean there's anything untoward going on in there. By all means, go along and have a chat with your GP about it. They'll take a look and just make sure everything's okay. But it sounds just like normal eustachian tube function to me. Yeah. We're coming up to about 5 to 10, so we'll give it about 5 minutes if that's okay, guys, and then we're going to go off. So we'll see what. So does having narrowing in your eustachian tube? Oh, I missed it again. Sorry, I didn't read it quick enough. Does having narrowing in your eustachian tube, which causes a lack of draining, a reason that ear infections may be worse? When you're looking at a problem with drainage through the eustachian tube, there are two different types of problems you can get. You can get this kind of chronic otitis media, which is basically just the middle ear effusion, which is where the fluid that normally sits there that's not infected gets thick, gets sticky, and sticks there. So they call it glue ear. Or you can get acute otitis media, which is where you get an infection in the middle ear space. Remember I said it was linked to the back of the throat, the eustachian tube. So you can get things like bacteria going up this tube here, and you can then get that forming as an infection behind the eardrum, which is a middle ear infection. Most people, if you've got something discharging from the outer ear, is usually an outer ear infection. Middle ear infections would be really, really painful. The classic signs and symptoms of that, really painful, and then you'll get a sharp pain, a lot of discharge from the ear, and that's where the eardrums actually popped and released the infected fluid, and then you get no pain after that then. So both will be treated with antibiotics there.
I've got one by here and I can't get it up. It's how do I safely scratch my ear?
How do you safely scratch it? There's a trick for scratching your ear. Don't put anything in it, because you're going to introduce something that shouldn't really be into your ear canal, and you run the risk of, especially if you scratch it with the corner of your nail, then you're going to get a bit of chance of infection in there. A really good way of doing it is if you see this part of your ear here, okay, if you close off your ear canal like this and give it a good wiggle up and down, what you get is a really good deep scratch in your ear, and you haven't introduced anything in there, so you don't run the risk of getting infection. Ooh, anybody else? Let's have a little look. My ears get quick. Oh, I'm trying to read these as quick as they disappear off my screen quicker than I can read them. Oh, that's okay. Somebody said thank you for asking for answering my question. You're more than welcome to. Here's a personal question: is Morris your middle name? No. When me and Mrs. B got married, I changed my name, so I am Mr. Morris Barber now, because we're obviously
Morris and a Barber.
And Mrs. B is actually Mrs. MB because she's Mrs. Morris Barber. So I changed my last name so we all have the same last name. Rhys is actually my middle name. So there we go. Let's have a look on here. How do you get rid of the waste? Okay, yeah. You see a lot of waste going into the tank. I showed you the tank. Most of that can just be thrown away. You can just dispose of it. It's kind of clinical waste, so it just goes into clinical waste. And you've got most of the tools we use are disposable, but it's a kind of trend within the industry now. It used to be that most of the tools would be autoclaved, cleaned up, and reused again. But most of the tools now are actually disposed of as single-use tools, which tends to obviously run the less risk of cross-contamination. And it tends to be the way the industry is going at the moment. You're getting a lot of single-use stuff. Yeah, a lot of single-use stuff. Let's have a little look. Curious if you talk to the patients during the procedure, kind of like you do on the video. Sorry if this has been asked already. I do sometimes. I always ask the patient, if the patient's feeling particularly nervous, some patients like me to talk it through. I will sometimes ask the question. I'll certainly explain as I'm going along, as I'm taking things out of the patient's ears. I'll show them what came out and show them exactly what's going on in there. But some patients do like me to talk it through, especially if they've come through from YouTube. They do like it, and they really like to see the videos at the end. So it's always nice to talk that through, so they get their own kind of personal talk through of their procedure as well. Let's have a look. Elaine Bell said, thanks so much for doing this live. So interesting and glad there was such a variety of questions. Yes, it's always lovely. I mean, it's lovely to get loads of different questions. I knew the video tonight was gonna throw up quite a few questions for everybody. I'm sorry I didn't get to answer the ones as you were kind of posting, because obviously I was trying to do the commentary live as well. But I hope I've answered all your questions. Both me and Mrs. B love doing the lives, and we love the engagement we get from you guys. It's, you know, although we see the views on the videos and we see the comments coming through, when there's so many of you online looking at this at the same time, it's really humbling to know that, you know, the videos that we do get, you know, they're all over the world. These, you know, people are coming in and talking to us. It's great. March, fascinating watching this tonight. Thank you for your time. You're more than welcome. You are more than welcome. Right, guys, it is 10 o'clock, and as much as I would love to keep doing this, I probably could do this all night. Yeah, because we love
I've
answering
enjoyed not being in front of the camera.
Yeah, Mrs. B's love not being in front of the camera and popping all my questions up on there as well. As much as I would love to stay here all night, I can guarantee that we probably would end up staying here all night and right the way through to tomorrow morning. But I do have a clinic again in the morning, so I have to go home at some point, I'm afraid. Thank you so much for all your comments. Thank you for your likes, your shares. If this is something you'd like to see again, then please let me know in the comments. And if you want us to do a live on, and keep an eye out for some other videos that are going to be coming soon as well. I won't go into any detail about that now, but they'll come up in a bit sooner for you as well. You will get another wax removal on Wednesday. We'll revert back to the old format for that one. I will need to do a new intro though, because I threw a lot of people because I had a beard on the intro and I haven't got one now. So we'll do that on Wednesday and another one on Friday. Keep yourselves safe, guys. Look after yourselves and one another, and we shall see you again really soon. I will try. I'll stop this now. There we go. Perfect. Bye, guys.